Welcome to UW Medicine Lung Transplant. This is the first of 3 UW Medicine Lung Transplant education videos. While they are available to be viewed by the general public, it is required that all UW Medicine transplant candidates and their caregivers watch these videos when actively under the evaluation process. All candidates in the evaluation process will receive an additional packet of education material that will include documents that will need to be signed and returned to the UW Medicine Pre-Lung Transplant Office prior to being placed on the waiting list. Candidates going through the lung transplant evaluation will also be required to watch the UW Medicine Pre-Transplant Pharmacist Education videos, Parts 1, 2, and 3. This is a brief history of transplant. The first organ to be transplanted was the kidney in 1950. Kidney transplants are still the most common type of organ transplant performed. Most research and new treatments are first tried with kidney transplant recipients. From 1963 to 1983, lung transplant was a research or experimental procedure. About 40 transplants were done during that time, and the longest living survivor only lived 10 months. In 1983, the first successful lung transplant took place in Toronto, Canada. The UW Medicine Lung Transplant Program began in 1991. Lung transplant requires a team of experts and a medical center that has specialized services available 24 hours a day, 7 days a week. The first lung transplants at UW Medicine were performed in 1992. One of those recipients lived 20 years after the transplant. UW Medicine has done more than 1,300 lung transplants. Usually, 55 to 65 people have lung transplants each year at UW Medicine. The goals of lung transplant are to possibly extend the length of the recipient's life and improve their quality of life. Some recipients will live longer with a lung transplant, but not everyone will have a longer life. Most recipients have a much better quality of life because they do not feel short of breath, do not need oxygen, and are able to be more active and have more energy. The lung transplant evaluation helps us further assess your lung disease. The evaluation helps us decide if lung transplant is the best treatment option for you. We look for issues that might make transplant unsafe or unlikely to help you. As you meet with members of our transplant team, we will outline ways to help you prepare for a lung transplant. The evaluation includes many tests, labs, and appointments. This slide shows common tests and labs that are included in the lung transplant evaluation. These tests and labs help us assess your organ systems and overall health to identify any risk factors present. Prior to scheduling the evaluation, a pre-lung transplant RN coordinator will review the specific tests and appointments required for you specifically. The selection committee includes the entire lung transplant team, which consists of transplant surgeons, pulmonary doctors, nurses, social workers, dietitians, financial counselors, and sometimes other specialists. Once you are done with your evaluation tests and appointments, your case will be reviewed by our lung transplant team during a selection committee meeting. The selection committee includes the entire lung transplant team, which consists of transplant surgeons, pulmonary doctors, nurses, social workers, dietitians, financial counselors, and sometimes other specialists. The team uses the UW Medicine lung transplant candidate selection criteria to decide if lung transplant is an option for you. Patients undergoing evaluation have been given a copy of the UW Medicine lung transplant candidate selection criteria. These criteria are used during the committee meetings to make one of 3 possible decisions: approved, deferred, or declined. If you are approved to be placed on the lung transplant waiting list, we will talk about the things, if any, that need to be done before you are placed on the waiting list. The committee may decide to defer a decision, meaning further testing, appointments, or preparation is needed. Once these steps are done, the committee will review your case again for a new decision. The committee may determine that the risks associated with lung transplant outweigh the possible benefit, and the person will be declined for placement on the waiting list. After your case is reviewed by the committee, someone on our team will always call and discuss the decision with you. You will also receive a letter in the mail documenting the decision. If accepted, we will also discuss with you the timing of placing you on the waiting list and whether the team recommends a single or bilateral lung transplant. Some patients could be considered for both options. Some insurance plans require a prior authorization for the lung transplant surgery. If required, we will submit the request and let you know when it is approved. This needs to be done before you can be placed on the waiting list and may take up to a week or more. Sometimes people can be on the waiting list at more than one transplant center. There is a pamphlet in your class packet called Questions and Answers for Transplant Candidates about multiple listing and waiting time transfer that explains more about this. This would require you to complete an evaluation and meet the selection criteria at each transplant center. The center that performs your lung transplant will manage your post-transplant care for a minimum of 1 year. The United Network for Organ Sharing, UNOS, is the organization that is responsible for the system that guides all organ transplants in the U.S. They manage national waiting lists for all solid organ transplants, not only lung, but heart, liver, kidney, and pancreas. They match donors to recipients 24 hours a day, 365 days a year. UNOS also keeps data on every organ transplant and ensures all policies are in place to best utilize the limited supply of organs, as well as making sure all people are given a fair chance at receiving the organ they need. UNOS is a great resource for transplant professionals, as well as patients and their families and friends. They also promote organ donation to the general public. Please visit the UNOS website at www.unos.org. The current lung transplant allocation and scoring system took effect in March 2023 and is called the Composite Allocation Score, or Lung CAS. At the time of listing, we enter data into the UNOS system and it calculates your score. The waiting list system for lung transplant is a national system and is the same at all lung transplant centers in the United States. A main goal of this allocation system is to reduce the number of deaths of people on the lung transplant waiting list, as well as to provide more transplants for candidates who have the most urgent need for a transplant and who are harder to match. The Lung CAS uses objective medical data about each lung candidate's needs and medical condition. It also uses factors about potential organ donors who may be a match for them. The score weighs the different factors used to make the match. Each factor gets a certain number of potential points, which are then added together to make up the total score. Medical experts have carefully determined the weight for each factor based on public input, as well as detailed study of lung transplant data. On the upcoming slides, we will break down the scoring in each category of this pie chart. Half of the lung CAS points come from a candidate's medical urgency and post-transplant survival scores. Medical urgency estimates how quickly a patient needs to be transplanted, while post-transplant survival estimates a candidate's likelihood of surviving at least 5 years if transplanted. Listed on this slide is the data that determines the points given in these two categories. These are taken from testing during your evaluation and updated as needed during follow-up appointments. Some factors in this list are weighted more heavily in the calculation than others. Your lung disease diagnosis alone can greatly impact your score. Candidates who are harder to match may get additional points. This priority is meant to give them more of a chance to get lung offers that could be a match. Candidates with harder to match blood types will have more points than those whose blood type is easier to match. Some lung candidates have immune system antibodies to proteins found on cells that mean they cannot accept an organ from certain donors. The Calculated Panel Reactive Antibody Test, or CPRA, measures the percentage of the population a recipient is not compatible with if they have these antibodies. Patients with a high CPRA, meaning they are harder to match because they have many of these antibodies, receive more points. Patients with no antibodies or low CPRA will have fewer points or none at all in this category. Donor lungs must be a size match to fit into the recipient's chest. Patients who are much shorter or taller than average will receive more points as there are fewer donors that are a similar height. Pediatric candidates are patients who are listed for a transplant before their 18th birthday, and they receive additional points. Candidates who have been a prior living organ donor, such as having donated a kidney, will also receive additional points. The final portion of the lung CAS addresses the time and effort needed to preserve and transport the lungs between the donor hospital and the transplant hospital. These values depend on the specific organ match and where the donor is located. This part of a candidate's total score cannot be calculated until there is a specific donor match. Therefore, the final CAS will change with each organ offer. In general, more points will be given in cases where the donor hospital is close to the transplant hospital and the lungs can be transported efficiently. In cases where the donor hospital and transplant center are farther apart, fewer points would be given. The actual CAS number does not give the full picture for how long a candidate may wait for transplant. Many factors are considered when matching donors and recipients, and we cannot predict when a donor that is a good match for you will be available, no matter your score. We encourage you to focus on the things that are within your control, such as exercising, maintaining good nutrition, and having regular follow-up with your medical providers. Before you are placed on the waiting list, a nurse will call you to ensure you are ready to be actively listed and understand when you need to contact the transplant team. Once you are placed on the waiting list, you will need to be ready to be called in for transplant at any time of the day or night. You will need to be within a reasonable travel time to UW-Medicine Montlake. If you need to relocate, this will be discussed with you during your evaluation, and you must relocate before you are placed on the waiting list. You will come to UW-Medicine Montlake for regular clinic visits and testing. These visits are usually every 2 to 3 months, but may be more often if needed. It is very important for you to call the pre-lung transplant office if you have any changes to your health, including new or worsened symptoms of your lung disease, a new diagnosis, or symptoms of an acute illness. The transplant team also needs to know if you have any changes to your caregiver plan or insurance. Try to stay as healthy as you can while you are waiting for a lung transplant. This will help with your recovery and outcome after your transplant. Although you have the right to accept or refuse a transplant at the time we call you with a donor offer, you should not be active on the waiting list if you are unsure about having a transplant. Please call the pre-transplant team if you are unsure about your readiness for transplant so we can support and talk with you about your decision. How much time someone will wait for a lung transplant is very difficult to predict. The SRTR keeps data on all transplant centers' waiting times. The statistics on the UW-Medicine wait time can be found on the SRTR website, www.srtr.org. This data is updated every 6 months, and a copy of our most recent report has been included in your education packet. Every year we have patients with very short waiting times, a day or two. However, some patients may experience a longer wait time related to factors that make finding an acceptable donor challenging. Next, we will talk about organ donor patients. The Organ Procurement Organization, OPO, takes care of organ donors. The OPO works with the donor hospital to identify, assess, and manage possible donors for organ transplant. The OPO works to optimize the function of all organs so they may be suitable for transplant. Donor patients are supported with a breathing machine, ventilator, medicines given by IV, intravenously, and other treatments and tests as needed. When a donor has been matched with one of our recipients, our team is paged and we begin a full assessment of the donor, which includes a full medical and social history. We also review chest X-rays, CT scans, as well as blood tests, including arterial blood gases, ABGs, to let us know how well the lungs are getting oxygen into the bloodstream. We work continuously with the OPO team throughout this process, sometimes over multiple days, to optimize the donor lung function up to the time of the transplant surgery. We are required by UNOS to tell you if risk factors have been identified in the donor based upon their social history. Donors identified with risk factors may make it more likely for them to be infected with hepatitis B, C, or HIV. Although every donor patient is tested for these viruses, a donor with risk factors could have a greater chance for a false negative test. Even when risk factors are identified, the chance of getting an infection such as HIV, hepatitis B, or C is extremely low. If we are calling you with a donor offer, we are required to tell you if the donor has risk factors identified. Although it is your choice whether or not to proceed with the transplant, our team feels this risk is very low. We do consider donors with active hepatitis C if consent is given, and we will discuss this in the next slide. Before and after transplant, all recipients are monitored for hepatitis B and C and HIV, whether or not the donor had risk factors. We will now talk about donors with active hepatitis C infection. Donor organs with active hepatitis C have been used for both heart and lung transplant recipients for many years with no difference in outcomes. Hepatitis C can result in liver damage after many years, decades, of infection, but can be cured with newer medications. While the virus will be transmitted from the donor to the recipient, treatment will start after the transplant to cure the infection in the recipient. This treatment may take 8 to 12 weeks, depending on the medication chosen by the hepatology liver team. You were given a consent form to sign if you would like to be considered for donors with active hepatitis C. This form is in the education packet and will need to be completed and returned to our office before you will be considered for these donor offers. You can also decide at any time, while on the waiting list, if you would like to accept organs from a donor with active hepatitis C. If you choose to sign this consent, you will have access to organs that might not be available to other recipients, and you may have a shorter waiting time. If you would like more information about hepatitis C positive donor lungs, there is a handout in your packet. This completes our UW Medicine education about the evaluation and preparation for being listed for a lung transplant. Our next education video will cover the process of being called in for transplant surgery, the surgical procedure, and the immediate post-operative recovery period. Please proceed to video 2 in the 3-video series.